For more than 47 years, our nonprofit, Resources for Seniors, has supported older adults and caregivers in Wake County. We can help in many different ways, including adult daycare programs, ramps and repairs, in-home supports, and consultation and referrals. Indeed, we're who to call when you're not sure who to call. Resources for Seniors stands ready to support you in your caregiving journey.
I'm Mark Costley, the founding attorney of Clarity Legal Group, the Triangle Area estate planning and elder law firm. You know those people who become overwhelmed dealing with the multiple challenges of being a caregiver? Clarity Legal Group helps people establish legal tools that avoid confusion, give them peace of mind, give them asset protection, and in some cases help them qualify for Medicaid. We help people get it right in the face of some of life's most important challenges. We don't just provide wills, trusts, and powers of attorney. We provide solutions and ongoing support. We provide clarity and peace of mind. It would be a privilege to help you.
Are you like 80% of seniors who would like to age in your current home? Call Wisdom Senior Care. Are you currently taking care of a loved one and finding yourself frustrated, tired, and even lonely? Call Wisdom Senior Care. Always available, dependable, and flexible. Come partner with Wisdom Senior Care, keeping wisdom at home.
Hello, friends and caregivers. My name is Sheri Omozokpea, and I am a clinical pharmacist at Senior Pharmacist. We're a nonprofit in downtown Durham, and we're focused on proper pharmaceutical care for older adults in our community. I'm here today to talk with you about caring for people with dementia from the pharmacist perspective. So of course that will include a lot of medications and treatments for dementia, along with best strategies for prescribing and deprescribing. So the goals of my presentation today are to review the types of medicines that are used to manage Alzheimer's dementia, as well as other dementia types, to share commonly used medications that can negatively affect cognition and should be avoided in patients with mild cognitive impairment as well as dementia, and to describe what older adults and their care partners can do to improve their health related to medication use. So before we go into detail with the treatments that are used for dementia, I wanted to share a little bit about the different varieties of dementia. And when I say dementia, I am referring to the umbrella term that refers to the declines in thinking and movement and cognition, generally speaking, that lead to interference with day-to-day living. As you can see from the slide that I have up now, the great majority of cases of dementia are as a result of Alzheimer's disease. And people with Alzheimer's tend to have trouble retaining newly learned information in the early stages, and that can progress to problems with judgment and reason, along to having problems with motor skills, such as walking and even swallowing in the advanced stages of the disease. There's also Lewy body dementia, which is characterized by episodes of decreased cognition and lack of awareness that seem to happen over hours or days, with a subsequent recovery in cognition for most patients. And one of the main things that differentiates Lewy body dementia from the other types is the presence of visual hallucinations. They can be as simple as maybe seeing something out of the periphery of one's eye, all the way to very advanced hallucinations where people are able to carry on conversations with loved ones that are deceased. There's also dementia as a result of Parkinson's disease, and Parkinson's disease is a disorder that starts to affect movement. And just as a side note, Alzheimer's, Lewy body dementia, and Parkinson's disease all show similar plaques of protein and tangles, and aggregations of protein in the brain. And some researchers even think that these three conditions are just different manifestations of the same problem in the brain with processing a certain protein. In addition to those types, there's also dementia as a cause of vascular disease that's been poorly managed or long-standing. So there are a few conditions like high blood pressure, high cholesterol, and diabetes that can lead to changes in the very small blood vessels that feed the cells in our brain. And as a result of those changes, they are not as able to give those cells nutrients, and that leads to neuron damage and cell death, which leads to a subsequent decrease in cognition. And if it weren't complicated enough, all of these things can happen simultaneously in a patient. They can be multifactorial, or what they call mixed dementia. That's less commonly diagnosed, but is still a definite possibility. So when we're talking about the progression of subjective memory complaints to what we would diagnose as full-blown dementia, that process can happen over a number of years or even decades. And the loss of, or the impairment of cognitive function over time is a normal part of aging. However, in dementia, it happens at a much more rapid rate than would be considered normal for a person's age. But before we get to that diagnosis of dementia, there comes first mild cognitive impairment. And mild cognitive impairment can be a result of the early process of dementia, of the damage that's happening to the neurons in the brain, or mild cognitive impairment can be a consequence of inappropriate medical treatment. So if a person is noticing changes in their thinking, it's always best to bring this up with a healthcare provider and get evaluated to see if there might be medications that are causing these problems. And depending on the medication and depending on how long the person has been exposed to this medication, those changes in cognition may or may not be permanent. So when we're talking about the goals of treatment for dementia, we have a few things in mind. Unfortunately, the therapies we have today are not able to cure dementia. So what we try to do with the medicines that we have available to us are to improve or preserve the ability of a person to carry out their activities of daily living, such as bathing oneself, getting dressed, driving for as long as possible, along with more complex tasks like going grocery shopping and financial management. Our goals of treatment also include trying to reduce the burden on caregivers, preserving quality of life, and stopping or at least slowing down the progression of the disease. So for today's presentation, I've broken down medicines that are commonly used in the treatment of dementia into 3 different treatment areas. The first one we'll focus on are the cognitive medications. These are medications that act directly in the brain to try to preserve what function is left. So when I refer to cognition, I am referring to a person's ability to remember and to communicate and to make good judgments, all of these things that are crucial to day-to-day living. And in dementia, obviously these things decline over time, but it's accelerated by loss of these neurons. So neuron loss, as I mentioned before, is a normal part of aging, but in people with dementia, it happens at a much faster rate due to the buildup of protein plaques and tangles, and that leads to decreased transmission of a neurotransmitter called acetylcholine. And acetylcholine is one of the chemical messengers in the brain that helps us to be able to learn, to be able to communicate, and even affects our motion because it's a transmitter that's used to stimulate action of muscle cells as well. So the medications used to preserve cognition are trying to achieve this by preventing the breakdown of this neurotransmitter acetylcholine. And there's also a medication that I'll talk about here that doesn't work quite in that way, but it helps to preserve cognition by blocking the excitatory effect of a different neurotransmitter called glutamate. So for this first grouping of medications that I have on my slide, these are the medications that are first used in mild to moderate dementia once a diagnosis has been made. These medicines are referred to as a class as cholinesterase inhibitors. And basically the way that they work is they prevent the breakdown of that neurotransmitter, acetylcholine, by inhibiting the enzyme that's responsible for breaking it down once the neurotransmitter has been secreted by the nerve cells. So first up, we have donepezil, or Aricept. That's available as a tablet or orally disintegrating tablet. That medication is dosed once a day and starts off with a dose of 5 milligrams and can be increased all the way up to a maximum of 23 milligrams a day as tolerated. And then we have galantamine or Razidine. That medicine is dosed twice a day as tolerated with a maximum dose of 12 milligrams every 12 hours, so total daily dose of 24. It does come as an extended release tablet as well, so that the interval of dosing is reduced to just one time a day. And then lastly, we have rivastigmine, which is dosed twice a day as a tablet, but if it's used as a patch, can just be applied once every 24 hours. All of these drugs, being that they're in the same class, have a similar side effect profile and can cause nausea or vomiting, diarrhea, dizziness, and potentially weight loss as well. Some patients have noticed a greater incidence of headache with donepezil compared to the other medications, and there's been more reports of vivid dreams in patients who take donepezil or galantamine. Of the treatments, no one is particularly recommended as the first one that you should try of the class. They're all viable options. But most of the time in clinical practice, what we usually see is someone starting on donepezil first, simply because it has a once daily dosing for the tablet formulation. Although it is also nice to see that these medicines are offered as orally disintegrating and solutions and even patches for patients who might have trouble swallowing. So as dementia progresses, the addition of another medication is usually recommended. And this one that gets added on next in combination with any of the others that I previously talked about is memantine or Namenda. And Namenda is dosed once a day, and the dose of it can be increased every week as tolerated. Like I mentioned previously, it's good that it's a once-a-day formulation because that means you just take it one time versus having to take a medication twice a day or having to remember a more complicated regimen. Memantine is also available combined with one of the other cholinesterase inhibitors, donepezil, and that medicine is called Namzaric. That's dosed once a day and can be increased as tolerated, but a patient does have to be stabilized on the 10 milligram dose of donepezil first before they switch to the combination, because it only comes as 10 milligrams in the combination of the extended release memantine and donepezil. So memantine is usually better tolerated compared to the cholinesterase inhibitors. Some people do mention increased blood pressure, headache, dizziness, and confusion with this medication. Because of some of the side effects that have been documented, it's not recommended for use in patients with Lewy body dementia because they already have a pretty high incidence of visual hallucinations, and unfortunately, memantine can contribute to that. For all of these medicines that are used to help preserve cognition, it's important to know that none of them should be stopped abruptly because of the high risk of withdrawal symptoms, and over time, stopping and starting the medicine can lead to declines in the neurotransmitter that we're trying to preserve, the acetylcholine. And so over time, that can lead to worsened cognition. If a person has been without these medications for more than a few days, it's usually advisable to restart at the lowest dose to decrease the risk of adverse effects from taking the dose that they were previously on. Now we'll focus on the medications that are used to treat some of the behavioral changes that come along with dementia. And before we get too far into that, I do want to just make the statement that sometimes behavioral changes in dementia are not going to be strictly related to the disease process. There may be other medical conditions going on that are leading to these changes in behavior. For example, if a person has a new behavior of becoming incontinent, there may be a reason for that being an underlying UTI, but because of the decreased ability to communicate how they're feeling or what's going on in their body, they may not be able to verbalize that. And so before starting medications that would focus on changing behavior, it's important to rule out any other treatable medical causes. So for some of the behavioral changes that we see in dementia, generally speaking, there's an increase in depression or anxiety and an increase in disturbances of sleep, along with hallucinations and other changes that I'll talk about a little bit later on. But for these medications, there are no specific medications that are approved for treatment of these conditions just in dementia patients. So they use medications that are typically used to help manage these conditions. For depression and anxiety, we have our SSRI class of medicines, and SSRI stands for Selective Serotonin Reuptake Inhibitor. So basically how these medications work is to keep the levels of the neurotransmitter serotonin in the brain higher than they would normally be to promote a sense of well-being. And so for those medications, we have sertraline or Zoloft, citalopram, which is also known as Celexa, and escitalopram, which is called Lexapro. We also have an older antidepressant medication that's commonly used called mirtazapine or Remeron, and this has a couple of other advantages that will become clear as I continue on with the presentation. Other antidepressants may be used as well, but these are usually the first-line treatments that we see. So when it comes to talking about sleep disturbances, the top priority when we're talking about managing that is making sure that a person or your loved one has good sleep hygiene habits in place. This would minimize the need for the addition of a sleep medication, and this is something that we'd like to try to do before we add on medication, because the commonly used medications for sleep can have some effects on cognition. If all of those changes have been made, then trazodone or mirtazapine, that Remeron that I was talking about before, could be good treatment options to start off with, but it's always good to discuss these with your healthcare provider. But other medicines that are used for sleep are less good choices simply because they do have effects on cognition that may or may not be lasting. We're still trying to figure out what the long-term consequences of using some of those medications would be. So when it comes to sleep hygiene, I just wanted to go in detail and share what I mean when I talk about sleep hygiene. These are things that honestly everybody can benefit from doing because it helps to promote the establishment of a good sleep-wake cycle. So things that you can do include sleeping only as much as you need to feel rested and then getting out of bed, keeping a regular sleep schedule, not trying to go to sleep unless you actually feel tired, getting regular exercise, although this should be done at least 4 to 5 hours before bedtime, so it won't interfere with your nights of sleep, avoiding caffeinated beverages after lunchtime to decrease the effects of caffeine in the evening, and avoiding alcohol near bedtime. That's really important to do because the alcohol may seem like it helps with promoting sleepiness and making you feel drowsy, but it has greater effects on your deep sleep and actually causes you to get poorer quality sleep. So you can also avoid smoking, especially in the evening. Try not to go to bed hungry, making the bedroom environment conducive to sleep, so making sure that blinds are drawn and that lights are turned down low and you have adequate covers. Avoiding prolonged use of light-emitting screens before bed, and dealing with worries before bedtime. So there are additional behavior changes that can be seen in our patients with dementia. Some may experience hallucinations of sight or sound, hold delusions, or become paranoid or suspicious of people around them. And these are actually symptoms that would fall under the clinical term of psychosis. And medications that are used to treat those are called antipsychotics. These should be added on very, very cautiously because all of these medications come with the warning that there's an increased risk of mortality in older adults with dementia. These medications can also be used for agitation or aggression, in addition to mood stabilizers like carbamazepine or valproic acid, which is also known as Depakote. So now I'll talk about some of the physical changes that can happen in dementia and how those can be managed with medications. Weight loss is a very commonly experienced adverse effect or symptom of dementia, especially as it advances. This happens in part because of difficulties with swallowing that develop because of the decrease in the acetylcholine neurotransmitter. I did mention before that it is involved with muscle movement or muscle stimulation, so decreased levels of that can cause problems with eating. To that end, nutritional supplements that are in liquid form like Ensure or Glucerna can be used to add in enough calories along with nutrients in a way that is easier to consume. But if a patient is still able to eat and likes to eat, mirtazapine can be added on to help stimulate the appetite. So Remeron is a medicine that has a few different ways of acting in a person with dementia that could be beneficial. Urinary incontinence is another very common physical change that comes along with the progression of dementia. Before we add on any medications, of course, we want to make sure that there are no treatable medical conditions causing this problem. And we want to institute behavioral changes that don't rely on medication, like avoiding caffeine, setting a schedule to go to the bathroom, and decreasing fluid intake closer to bedtime. But once all of those things have been tried, it's very important to choose medication to help with incontinence that will have less of an effect on the brain, such as mirabegron or Myrbetriq and trospium or Sanctura. There are other medications that are indicated for helping with incontinence, but they are highly anticholinergic medications. And so they decrease the availability of that neurotransmitter that we're trying to boost up with the treatments that we have for the cognition portion of treating dementia. But the two medications that I've mentioned here aren't able to cross the blood-brain barrier, so they have less of an effect on cognition. And two here, I wanted to mention the management of chronic conditions. These are physical changes that aren't always going to be seen, but do have an impact on the trajectory of a person's cognitive function. Like I mentioned at the beginning, vascular diseases including hypertension or high blood pressure, high cholesterol, and diabetes all have changes or can make changes over time on the small blood vessels that feed the brain. And so optimal management of those conditions is key to preserving cognition long term. So there's a lot of different medications that can be used in the treatment of dementia. And oftentimes, older adults will also have other concurrent conditions as well that they're getting treated for. So that can add up to a great number of medications, a lot of financial burden, and unfortunately, there isn't a wonder drug that has an all-in-one treatment for these conditions. But there are certain things that you and your healthcare team can do to try to help manage all of these medications and conditions in a way that works out for everyone. Senior Pharmacist in downtown Durham is an organization that can help with multiple facets of growing older, especially when it comes to taking medications. We offer medication therapy management in the form of comprehensive medication reviews, where a patient can come in and sit down, and caregivers are welcome, of course, to sit down with the pharmacist to review their medication regimen, to learn more about the medicines that they're taking, and to optimize these therapies. In addition to medication therapy management, Senior Pharmacist also offers Medicare counseling to any Durham resident that is eligible for Medicare, regardless of age or income. For those who qualify, who are 60 years of age and older, who are on Medicare and meet certain financial criteria, we also offer direct financial assistance in the form of a copay card that they can use along with their Medicare coverage to reduce copays. And while all of those other things are going on, we also provide tailored community referrals to patients and their caregivers if they are looking for services like tax preparation, estate planning, and financial management. So if you're interested in any of those services or to learn more about what we provide at Senior Pharmacist, I encourage you to visit seniorpharmacist.org, where we have a calendar of events and also have a webinar series about the basics of Medicare. So with Senior Pharmacist, our main goals are to try to tackle a lot of the major public health concerns that are associated with medication use. In my experience with the organization, the chief problem that we tend to see is non-adherence or medications that are unnecessary. So medications absolutely don't have any effect in people who don't take them. And there may be different reasons why they're not able to take them. And that's something that we try to drill down on at Senior Pharmacist when we talk with our patients. And sometimes the best medicine for a condition or problem is no medicine at all. We always recommend non-pharmaceutical strategies before adding on or maybe getting rid of a medication. Other problems that come along with medication use that are of concern to the public are underuse. Most of the time, underuse happens as a result of cost or not being able to get a medicine covered by a person's insurance plan. They just might be taking the wrong dose by their own mistake or misunderstanding about how the medicine works. And there's non-adherence as well. And there are multiple different reasons why a person would be non-adherent to medications that I'll talk about a little later. There's also overuse or inappropriate use of medications. Sometimes when patients are seeing a specialist in one area and have a general practitioner in another health system, their care becomes uncoordinated, and so the doctors don't know what's being prescribed by the other providers for the patient, and that can lead to overprescribing and use of multiple medications for the same condition when maybe one or two medications or fewer medications would do just fine. And then another concern that we have when it comes to the public's health is promoting health literacy. And when I talk about health literacy, I'm talking about a person's ability to obtain, interpret, and understand basic healthcare information and to use that information in a way that promotes their health. So if all of these factors are going on, that can lead to the development of medication-related problems for our older adults. And people who are at really increased risk for these problems are those who are on multiple medications, especially ones that have narrow therapeutic range drugs on board. For example, things that are used to treat diabetes can be a narrow therapeutic range, or blood thinners, where if the dose is too low, they're not getting enough benefit from the medication. But then if the dose is too high, they could experience adverse effects from the medication and negative outcomes. And there's a very fine line or a very individualized dosing for those kinds of medications. People who have decreased kidney and liver function are also at risk of medication-related problems simply because their bodies aren't able to eliminate the medicine, as well as people without those issues. People with comorbidities or poorer perceived health may also be at risk for these problems simply because of the confounding factors that might go on with having multiple disease states and potentially having a medication that is showing symptoms that is in line with one of these, so it's harder to tease out what the root cause might actually be. People who are in these care transition points are also at very increased risk for medication-related problems, like people who have left the hospital or facilities, as well as people who have more than one prescriber or use more than one pharmacy. That's that polypharmacy that I was talking about before. And of course, one of the groups that we're mainly concerned with are older adults with cognitive impairments, just because they may have a decreased understanding of how best to use their medications. So the good news about polypharmacy and medication-related problems is that most of the adverse effects or poor outcomes are things that can be prevented. And so if we have healthcare professionals looking into these things, we can prevent a lot of them from happening. But as things are now, for every dollar that we spend on medications, we spend $1.36 on dealing with medication-related problems. And so that ends up costing the healthcare system quite a bit of money. So the goal of medication therapy management is to maximize the benefit of taking medications while minimizing the risks, and to do that in a really cost-effective way. So if those goals of medication therapy management are achieved, then these dimensions of adherence that have been identified by the World Health Organization are likely to be minimized. But I'll talk about some of the reasons why a person might be non-adherent to their medications. So there's the socioeconomic factors, as in not being able to afford a medication or not having coverage for it with their insurance. Poor directions or poorly misunderstood directions, and that being a health system related factor. If they already have a complex regimen and a high pill burden, that can make things harder to understand and harder to stick with. If they're having adverse effects from certain medications, that can affect adherence as well. And of course, there's the patient-related factors. If they are having trust issues with their providers, are not able to remember to take their medications, misunderstand what the medications are for, or are worried about becoming dependent on the medications, those can affect adherence as well. So one of the goals that we have at Senior Pharmacists is to promote deprescribing, which is basically just the practice of eliminating unnecessary medicines in a way that promotes the health of the patient. So polypharmacy is associated with increased risk of adverse events and can also lead to a prescribing cascade where medicines are added on to treat adverse effects of maybe an original medication or adverse effect that over time basically becomes a big mess in terms of medication management. So deprescribing can help to tackle that as well. So other advantages of deprescribing include improving the function and cognition of a patient, decreasing their risk of falls, reducing troublesome signs and symptoms, decreasing that pill burden that I spoke about earlier, and of course, minimizing expenditures or spending on their medications. So some of the potential pitfalls with deprescribing are figuring out the best way to actually stop a medication. So it's always recommended that a patient talk with a healthcare professional before they discontinue taking the medication. For other barriers that might exist, there may not be a protocol or process in place for stopping some medications, and so doctors or providers are more hesitant to stop something because of the concern of increased adverse effects, or just fear on the patient's behalf that taking the medication or not taking the medication anymore, rather, would lead to problems down the line. So some of the targets of deprescribing are medications that are featured on Beer's list, which is a list of potentially inappropriate medications that should be reviewed for safety and efficacy in older adults. That list is now managed by the American Geriatric Society, but it emphasizes deprescribing medications that are unnecessary, that may be causing more harm than good, and to streamline a person's medication regimen. So here is a table of commonly used medications that may have effects on cognition as listed on Beer's list. At the very top, you'll see first-generation antihistamines, and a lot of these products are available over the counter. So when we sit down and talk with patients, we always recognize the use of these medications and try to figure out if there are less harmful agents that could be used instead. These are especially challenging because, as I mentioned before, some of them are over the counter and very easy to obtain. And, as a person, progress through adulthood, they could take those medications just fine before, but as aging progresses, there are changes in how our bodies are able to handle medication and unknown effects on cognition from these medications as well. There's also older tricyclic antidepressants, skeletal muscle relaxants, older medicines used to treat Parkinson's disease, antispasmodics, and barbiturates. So if you notice that you're taking any of these medications or your loved one is taking them, it's always a good idea to review the necessity of those medications with the provider and to bring up any concerns that you might have about those medicines affecting cognition, not only in the short term, but with long-term use as well. Other two big classes of medications that should be used with great caution in our older adult populations are benzodiazepines and non-benzodiazepines. These medications may have a good indication, especially if they are being used to manage seizure disorders or sleep behavior problems, or used as anesthesia before getting a procedure done. However, the exposure to these medications over time can increase the risk of cognitive impairment, delirium, falls, fractures, and can increase the risk of motor vehicle crashes in older adults. So if these medications are going to be used, it's best to use medications that have a shorter duration of action versus the longer acting ones. And for the non-benzodiazepines, or the Z drugs as they're commonly known as, these are medicines that act on the same receptor as the benzodiazepines, but are purported to have decreased cognitive effects compared to the benzos. But the cognitive impact of taking these medications long-term isn't well known, and they actually don't have that great of an impact when it comes to trying to manage problems when it comes to sleep. And they just have a lot of other risks that make them, hopefully second or third line choices when it comes to managing those problems in our older adults. So we also have antipsychotics as a group of medications that might potentially be inappropriate for our older adults. As I mentioned before when I was talking about the treatment options that are available for the behavioral changes that come along with dementia, these should be used only as a last resort if other methods have been tried and failed and the person is presenting a danger to themselves or others because of the increased risk of cerebrovascular accident or stroke, and greater rate of cognitive decline that's associated with these medicines in our dementia population. So, in addition to medicines that work directly on the brain, on Beer's list that I had previously talked about, there are medicines that don't have actions on the brain but can still affect cognition. Some of those include diabetes medicines, both oral and injectables like insulin, along with sulfonylureas. That's a class of oral medications that can be used to lower blood sugar. And so with these medications, if they are used inappropriately, they can lead to prolonged hypoglycemia or low blood sugar, and those can have temporary effects on cognition by starving the cells in the brain of the nutrients that they might need, because our brains do rely heavily on glucose. But on the same side, or on the other side of the coin, management of diabetes is really important because elevated, uncontrolled high sugars can lead to small vessel damage and lead to that same poorer outcome when it comes to cognition in our older adults. So here are the takeaways for deprescribing and the things that we try to do when it comes to managing medications. It's not advised to treat side effects. It's best to remove the offending drug when it's possible. To start low and go slow with medications that are being added on. That is maybe one of the biggest things that can be done to promote good outcomes in our older adults, and especially if these medications are active on the nervous system, it's best to start with one medication at a time and to slowly increase that as needed. The need for clear directions is something we try to promote. And if directions have been changed at an office visit, for example, it's always best to try to get a new prescription reflecting that change so that the patient, their caregiver, their provider, and the folks at the pharmacy are aware that there has been a change in how that medicine is supposed to be taken. Clear indications are also a big thing that we try to promote at Senior Pharmacist and in general with medication therapy management. However, when it comes to adding indications to the labels of medications, the pharmacist has to have it on the prescription that they receive from the provider in order to put it on the label by law. So that is one of the things that you can try to ask your provider to do for you during your office visits. Simplifying the regimen is also a big benefit. And for example, if a medicine can be taken every 8 hours, if it's possible, it could be more simply stated as taking a medicine 3 times a day with meals. So take one every 8 hours would turn into take one after every meal. And the use of medication records is very important to give the caregivers and the patients themselves a sense of agency in their care. So if they have a list of medicines, they know their insurance, and they know the names of their providers and are able to take that information with them, that decreases the risk of having missing information or having a poorer outcome because of lack of knowledge of some of those medications or allergies as well. It's always very important to make sure that all of the people who are involved in your care are aware of these things. So here I have just made recapped the medications that are most likely to contribute to cognitive decline, and that makes them really good targets of deprescribing. So just to review, those are some of the anticholinergic medicines, antihistamines, the benzodiazepines that are commonly used for anxiety, as well, along with the Z drugs that are commonly used for sleep, muscle relaxers, and then using medications in a way where blood sugar and blood pressure are too tightly controlled and can lead to changes in cognition and potentially even falls, along with proton pump inhibitors, which I didn't touch on too much during the course of the presentation, but there has been research that has shown some link between the use of proton pump inhibitors long term, so over the course of years and years, and changes in cognition as we get older. So it's always good to reevaluate use of these drugs and to try to eliminate them if possible. Here we have medicines that are also used to treat some of the symptoms of dementia or those behavioral problems that have that warning that they are more likely to lead to incidents of stroke or other problems that would reduce cognition in our dementia patients. So those are good targets to try to at least reevaluate their use periodically. And most of all, I just wanted to emphasize that there needs to be a lot of support for individuals with cognitive impairments because the more complex a regimen is, the more likely it is that something may be forgotten or misunderstood. So fewer is a better approach for those patients. All right, and I know that was a lot to take in, but I'll be happy to respond to any questions that you might have, but that brings me to the end of my presentation, and I hope that you took some good things away from this, and thank you so much for your attention.